everyone, I'm Peter Tang from Taipei Veterans General Hospital. In this next section, I'll talk about the workup and diagnosis of this patient. First, let's look at the lab analysis. We can see that his electrolytes, liver function, renal function, CRP, glucose, and complete blood count are within the normal range. His free valproic acid level is 10.3 and total valproic acid level is 111. We also arranged brain MRI. On the left, we have the axial T1 weighted image. We noticed brain atrophy especially at the frontal and parietal regions, but we did not find any focal lesion. On the right, we have the coronal T2 weighted image. The brain atrophy is quite obvious here, but again we did not find any focal lesion, and his hippocampus seems to have a normal morphology. Here we have his interictal FDG PET. On the left is the axial view. On the right we have the coronal view. We can see that metabolism of both hemispheres seems quite symmetric. These are the results of his neuropsychiatric examinations. Our patient had 6 years of education with low academic achievements. He was a laundromat owner and was independent in activities in daily living. His estimated IQ was 92, but instead he had a full-scale IQ of 66, which was in the first percentile. This means that he has a low level of intellectual functioning. On the right chart, we can see the reported severity of symptoms such as depression, anxiety, and paranoid ideation. The T-scores of each symptom is between the 40th to 60th percentile, which means that the patient has no remarkable psychiatric symptoms. We mentioned previously that the patient's grandparents, parents, and siblings did not have epilepsy, but actually his son does. His son had his first seizure at the age of 7. It was limb convulsion, first found during sleep. He did not have aura. During the ictal stage, he had right limb dystonic posturing followed by chewing and then dystonic posturing of 4 limbs and then grunting. He had impaired awareness during his seizures, and his heart rate would increase from 55 to around 85 beats per minute. After that, he would fall back asleep. The duration of his seizures were usually between 30 to 60 seconds, and the frequency was once to twice per month. It always happens during sleep. His son was on a monotherapy of oxcarbazepine 600 mg BID. He showed good response to these medication. He had only seizure attacks once every 3 to 4 years and was usually due to missed doses. Okay, here we can see more information about his son. He had a normal birth and developmental history and had no febrile seizure or CNS infection. His EEG showed a posterior dominant rhythm at 9 Hz and no unequivocal epileptiform discharges. His brain MRI showed no structural abnormality, and brain PET showed no abnormal uptake. His full-scale IQ was 108. Okay, now I'll make a brief summary. Regarding the seizure types, our patient had focal hyperkinetic seizures, and his son had focal motor seizures. These seizures all occurred during sleep. Regarding comorbidities, our patient had intellectual disability. And as for the etiology, we didn't identify any structural or metabolic or infectious or immune-mediated cause. But because the patient and his son had epilepsy with a similar presentation, so we suspected a genetic cause. So we extracted their DNA from the peripheral blood and performed targeted sequencing. And we discovered a heterozygous variant in the MPRL2 gene, the C970A to G mutation. It caused a missense mutation. It was found in both the patient and his son. This variant was not reported in these databases including ClinVar, Genome AD, Exact, 1000 Genome, and Taiwan Biobank, and was also absent in 1000 controlled chromosomes. This variant was designated as likely pathogenic by the ACMG guidelines. So what is the function of the MPRL2 protein? Before answering that, we need to take a look at this mTOR pathway. This pathway is a nutrient-sensitive pathway that regulates cell growth and metabolism. When nutrition is abundant, this pathway is activated and it promotes cell growth. But when in low energy, this pathway is inactivated and growth is inhibited. Now, the major component of this pathway is the mTOR complex 1. Next to the complex is a structure called RAG. This RAG is like a switch. During low energy state, this switch is turned off by a complex called gator 1, which in turn inhibits this pathway. So this gator 1 is like a brake for the mTOR complex 1 pathway. Now, the MPRL2 protein is one of the three components in this gator 1 complex. And because our patient has a mutated MPRL2 protein, his gator 1 might be malfunctioning, causing this mTOR complex 1 pathway to overactivate and becomes desensitized to nutrient starvation. So this kind of condition has been associated with malignancy, focal cortical dysplasia, and focal epilepsies. Okay, now that we've identified a possible cause, which is the MPRL2 mutation, in the last bit I would like to talk about the diagnosis of an epilepsy syndrome. The first epilepsy syndrome that came to our mind was the sleep-related hyperkinetic epilepsy, the SHE. According to the ILAE classification, the SHE had these clinical features. So first, patients usually have focal motor seizures occurring from sleep. They had vigorous stereotyped hyperkinetic movements and autonomic signs or vocalization or negative emotional expression. They usually have abrupt onset and offset, typically less than 2 minutes. These patients typically have their onset in adolescence, and there is a slight male predominance. Usually, patients have normal perinatal and developmental history and a normal neurological examination, but sometimes they may have intellectual disability. Most patients respond well to the first-line anti-seizure medications, but if they have intellectual disability, they are less likely to achieve sustained seizure remission. So these features are quite compatible with our patient's presentation. The EEG in patients with sleep-related hyperkinetic epilepsy usually have a normal background. The interictal EEG may show epileptiform discharges in the frontal areas in about half the patients, especially during sleep. The ictal EEG may not show a definitive ictal pattern, or it may show an origin in the frontal or extrafrontal areas. As for the etiology, it could be genetic, structural, or acquired. Neural imaging usually shows normal results. There may be a mutation in one of these genes, such as DPDC5, MPRL2, MPRL3, and such on. And these patients usually have an autosomal dominant mode of inheritance with 70% of penetrance. This chart shows the diagnostic criteria from ILAE for sleep-related hyperkinetic epilepsy. First of all, we can see that our patient and his son fulfills the mandatory criteria. And most importantly, they do not have any alerts or exclusionary criteria. Another syndrome we should consider in this family is the syndrome of familial focal epilepsy with variable foci, or FFEVF. This syndrome can also be caused by mutation in the gator complex. We can see that our patient and his son generally fulfills these criteria, and they do not have any alerts or exclusionary criteria. However, there are some differences between SHE and FFEVF. In SHE families, all the affected family members have sleep-related hyperkinetic epilepsies, whereas in FFEVF, the family members have focal seizures originating from different regions. And furthermore, a predominance of awake seizures could be seen in family members of FFEVF, but this was not seen in our patient or his son. Here I'll make a brief summary of the patient's workup and diagnosis. On his brain MRI, we did not identify any structural lesion. His brain PET did not show any abnormal metabolism, and the patient had a full-scale IQ of 66. Targeted sequencing revealed a C970A2G mutation in the MPRL2 gene in both the patient and his son, and this was designated as likely pathogenic according to the ACMG guideline. The tentative diagnosis at the epilepsy syndrome level is the familial sleep-related hyperkinetic epilepsy, but the familial focal epilepsy with variable foci cannot be fully ruled out at the current point. We may have to continue following the patient and other family members to see if they develop seizure from a different region, and if they do, the final diagnosis may be FFEVF. Okay, that's it for part 2. Thank you for your attention. In the next section, Dr. Tsai will tell us more about the diagnosis and management of this patient.